Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello and welcome, listeners. This is Kevin MacPherson, and today I have the privilege of interviewing Dr. Bryan Bond on his article, Effective Spinal Manipulative Therapy on Mechanical Pain Sensitivity in Patients with Chronic Nonspecific Low Back Pain, a pilot randomized control trial. This article was found in the Journal of Manual and Manipulative Therapy in 2019, and before we get into the article, I'm going to give you a synopsis of Dr. Bond's background. And let's just say that it has a lot of degrees involved. So he has two Bachelor's of Science degrees, one in kinesiology and one in human biology. He has a master's degree in biomechanics. And then more relevant to our listening audience, he has two doctorate degrees, one of which is a uh, clinical doctorate, and then the other one is a research doctorate. And that clinical doctorate is a Doctor of Chiropractic degree from the National University of Health Sciences. And then his research doctorate is a PhD in rehabilitation science from the University of Kansas. Now, at present, Dr. Bond is a full-time faculty member and full-rank professor at the University of St. Mary, where he is also the co-director of research in the Department of Physical Therapy. He does instruct in biomechanics, human imaging, and musculoskeletal assessment. However, prior to going into academia, he did spend several years in private practice, which means he brings in that clinician hat to a lot of his research, making it very relevant to our practicing clinician audience. So, that all being said, Bryan, how are you doing today?
Things are going great, Kevin. I just want to thank you for the opportunity to speak with you today to discuss our paper. I also appreciate the opportunity to discuss the paper with your audience as well.
All right, so introductions aside, Bryan, do you mind just providing the audience a brief overview of this project and a brief overview of your results?
Yes, of course. Thanks, Kevin. I appreciate the question. So this was a pilot randomized clinical trial, and we were examining the effects of spinal manipulation on mechanical pain sensitivity as well as clinical outcomes. Our central hypothesis was that spinal manipulation would reduce hypersensitivity to mechanical stimuli. In addition, it would also improve the clinical outcomes in chronic nonspecific low back pain patients. We used pressure pain threshold as an indicator of mechanical pain sensitivity at three testing sites. The first was a site that we described as a local site, and that was lateral to the L5 spinous process. The second site was what we describe as a regional location, and that was at the tibialis anterior muscle. And the third site was a remote site, and that was at the lateral epicondyle. In addition to looking at pain pressure threshold, we also captured clinical outcomes, and those included the numeric pain rating scale and the Oswestry Disability Index. We randomly assigned 29 subjects to either a manipulation or sham manipulation. As far as our results, we observed a significant main effect for time, signifying reduced hypersensitivity or increased pain pressure threshold at local and regional locations at 3 weeks. Furthermore, we found significant main effects of time indicating improvements in pain and disability from baseline among all participants, regardless of intervention. However, no between group differences were observed in pain pressure threshold, clinical pain, or disability between the sham and the spinal manipulation group at 3 weeks.
So that kind of hit me at the core a little bit as a manual therapist. Now, I've got a thought process as to why I think you got similar outcomes. Uh, if not just a bias, it's taking me there. But before I can ask that question, do you mind, Bryan, giving us a description of that manipulation and the sham manipulation so that our audience has an idea of what they look like?
Yes, the manipulation group involved the patient lying in a supine position with the spine in a position of lateral bending and rotation, followed by a high velocity, low amplitude thrust to the lumbopelvic region. By contrast, the sham group placed the patient in the supine position, but without any accompanying lateral bending or rotation. In other words, the spine was in a neutral position, and that was followed by a high velocity, low amplitude force applied to the table. We used the same sham manipulation as a previous paper by Bialowski in 2014. In that paper, Bialowski conceded that the sham manipulation applied a mechanical load to the spine. Scientific models suggest that the effects of manipulation may be the result of a mechanical stimulus that elicits a cascade of neurophysiological effects, and then this perhaps accounts for the therapeutic effects associated with manual therapy. So our findings that both manipulation and sham manipulation produced hypalgesia at sites local and distant to the region of pain are perhaps indicated that the application of a mechanical load to the spine elicited a neurophysiological response, but perhaps suggests less importance of how the force was applied. Perhaps it's just an appropriate amount of force in a general region with less emphasis on the specificity of the applied force.
So again, we've got an article that really challenges that specificity, and I'm really glad that uh, you provided that explanation because one of the things that has troubled me as a practitioner, especially when I was learning manipulative treatments, the thrust manipulations more specifically, was the specificity that we've been taught. You need to put the person exactly here. You need to put this load exactly this way. You need to make sure that the direction of the force matches this direction. And I remember going through that training, and I remember getting back to the clinic to work on my patients, and my initial goes at thrust manipulation were anything but specific. I mean, the, the idea of locking them down or getting a pre-manipulative barrier and whatnot never really looked that great during those first months, if not years or so. But when I did a test retest, when I looked at getting that person off of the treatment table after whatever I did that I called a manipulation at the time, their test retest often, provided they were a patient that fits that category, looked better. It always looked better. So to me, it provides a little bit of validation of not necessarily being as focused as a newer practitioner and learning specificity. Do you think I'm making too big of a jump there, or is that something that I might be on the right track with?
No, I think you're on the right track. I think just personally, anecdotally, I've had the same experience myself as a practitioner, where perhaps my setup or my application of the force wasn't what I might consider to be ideal or textbook, or wasn't the way I wanted it to be. But perhaps once again, it was just the right amount of force in the right general area that again stimulated the nervous system, and perhaps that was the trigger for overriding the patient's pain experience that they were having. So no, I would agree with you. I think there are other papers that also suggest that the idea of specificity perhaps maybe wasn't as important as it was considered, you know, 10, 20, 30, 40 years ago, particularly if we consider the biomechanical model of manual therapy and how it works basically. So perhaps the neurophysiological response, maybe a shift towards the neurophysiological model, neurophysiological response, accounting for the reduction in pain. Perhaps the idea again of specificity isn't important as perhaps we once thought. Not to say that isn't something we should consider. Again, I think what it might be is the right amount of force in the right general area, and we see improvements. If you look at Bialowski's model, There would be peripheral responses as well as central responses, which would include the spinal cord and supraspinal centers. And so there is evidence to suggest that there is a local response, right? There's a response locally. So again, applying the force in the right general area again might be helpful in terms of overriding the pain response.
Very good synopsis there. So if I take you to a different direction on this one, we saw in your paper, at least if I interpreted correctly, that there was local changes in that pressure pain threshold, uh, but it seemed like the local changes might have been a little bit less than regional changes. Did I read that right? And if so, can you talk about that a little bit?
Yes, our results indicated less change at the local site compared to the regional location. In addition, between subjects effect size was greater at the regional site compared to the local site. It perhaps indicates a greater central or global effect of manipulation on pain rather than a peripheral effect. The caveat to that again is again this was a pilot randomized clinical trial, so again we had a limited sample size, but perhaps again there's a greater global or central effects if we look at the differences in the local site compared to the regional site, put those in that context basically. So
Okay.
the more distant the effect of manipulation on pain relative to the site of pain, perhaps the more likely a central effect of manipulation on pain, which again would include the spinal cord and supraspinal structures.
And based off of your outcomes, is it also fair to say that there does seem to be some shared innervation from the region that was theoretically targeted by way of mechanical load, one through the spine, one more through that contact point with the pelvis, not with the spine in a loaded position? And then similarly innervated structures down the chain versus what we saw, which was really not much of a change at that elbow. Am I reading too much into that?
No, that's correct once again. So again, we tested three anatomical locations. The local site, which was spinal. The regional location was the tibialis anterior muscle. So again, there would be expect you would expect some innervation, overlap, and then the remote testing site was the lateral epicondyle. And again, the more remote the changes or the effect on pain pressure threshold, the more likely there is a global or central effect, perhaps for the manual intervention. So we didn't see any changes, significant changes at the remote testing site, but we did see changes at that tibialis anterior site. Again, there is overlap and innervation, lumbopelvic area down into the lower quarter.
Good. So it speaks to me that, at least from a specificity standpoint, if you're trying to use a spinal treatment or a perceived spinal treatment, you should at least try to target that to an area that has similar innervation. If you have somebody who has more of a peripheral pain, maybe not necessarily a radiculopathic pain, but a peripheral referred pain, is that also possibly being read here from a preliminary evidence standpoint?
Yes, correct. I would also agree with that as well, Kevin. Certainly, that obviously there's different types of low back pain. We were just looking at the category of chronic non-specific low back pain. People basically that didn't have any symptoms below the knee. But certainly clinically all the time we do see people with that chronic non-specific, if you will, low back pain where there is a referral of pains, maybe a little bit distally, doesn't maybe go below the knee, but there's still some referral, some overlap there. So again, clinically, that might be an application for the interpretation of our results in the context of would be something to consider with patients that perhaps don't have any evidence of like radicular pain below the knee.
Thanks for clarifying my thought processes and providing me a better insight to the outcomes of your research and how to incorporate that clinically. Full disclosure, I do work at the University of Florida, so Bialowski's office is less than 15 feet away from me. So I get kind of absorbed within his world. And you do reference that both the model as well as the sham intervention that was used in his works. So my question for you is a little bit left field, but
Mhm.
did you happen to look at yellow flags or other contextual factors of the interaction between that research practitioner and the research subject in this study?
Yes, although not reported in this paper or published anywhere yet, we captured information about patient expectation and satisfaction. And as a theoretical model by Bialowski, including the updated model published in 2018, outlines the importance of moderators of pain experience, such as the psychosocial and psychological aspects. We just have not done a complete analysis of that data yet. However, we did capture, again, patient expectation and satisfaction.
And that brings me to a question that might be helpful for a lot of our clinician audience because it does seem that researchers do tend to collect a lot of information and then tend to either use subsequent articles to disseminate all of that data or the outcomes of crunching all of that data in boluses. Is this something that is very consistent across the board, or am I just seeing a pattern that's really not there?
Yes, I think that often what you find is a study design, and perhaps there's multiple aims and or hypotheses associated with that study design, and so perhaps one paper only reports one or two of your specific aims. So you're you're trying to capture a lot of information, and you do sort of have a tendency to disseminate it in small little sound bites, basically. And in addition to this paper that's reported where we captured information on pain pressure threshold and clinical outcomes. I mentioned that we did capture a little bit of some psychosocial information, but we also then did also capture information related to kinematics as well. And so just full disclosure about this sort of overarching project. This was actually my dissertation project for my PhD, and so I did also capture some other information in addition to the patient expectation and satisfaction.
And you're still at the number crunching phase with that, or have you already submitted?
So I do have two other manuscripts that are in the pipeline. So I also, as part of this project design, I examine the effects of manipulation on trunk kinematics in the same cohort of subjects. I hope this manuscript might be published this year. It is in the pipeline; it's ready to go. In addition to looking at kinematics, I also have another manuscript where we examined the relationship between the spinal manipulative therapy induced changes in pain pressure threshold and the numeric pain rating scale, the Oswestry Disability Index, and kinematics. So, in other words, we're trying to establish whether or not pain pressure threshold may be a prognostic indicator of clinical outcomes. So that's another manuscript that I'm trying to get in the pipeline and trying to get published this year as well.
Oh, that's very interesting. Uh, and just more of a personal question, but do you end up seeing like a threshold? Is there like a certain amount of pressure that is related to outcomes with the PPT assessment, or
So, Kevin, you're reading my mind. So there actually, I don't have that as a formal manuscript right now, but I have sort of post hoc looked at the group that received the intervention. So I had two groups, the sham as well as the treatment group. And I have a small enough sample that I can just plot. Um, I can plot the pain pressure threshold, for example, for the 14, 15 subjects that were in the intervention group. And interestingly enough, when I plot those out over time, so if I take each subject and I plot pain pressure threshold over my 3 time points, pre intervention, immediately post intervention, and at 3 weeks, when you look at that plot, um, just crudely looking at analyzing, there appears to be a relationship where the individuals that seem to have a lower pain pressure threshold seem to be the ones that are more likely to have an increase in pain pressure threshold at 3 weeks. Keep in mind, again, that's just a very, we haven't got into like an in-depth analysis. It's a limited sample size, 14, 15 subjects. Um, this is a pilot study, but it just appears that there is perhaps a trend or a relationship and maybe a prognostic indicator where, again, the people that are coming in with chronic low back pain that appear to have, more sensitivity, more sensitization, those appear to be perhaps the ones that are are likely to be the responders, if you will. Again, um, I just want to emphasize that's just a preliminary analysis. We haven't got into like a full
Oh,
analysis.
and I understand, and I'm sure our listeners will follow that. I mean, clinically, it does make sense, but has any good evidence-based practitioner will be able to vouch for or vouch to make sure that they check their clinical observations with that research. And of course, it's got to go through its steps to get to being published and having a story to build up for it. So we get it,
Mhm.
and we won't hold you to anything here in specific.
I appreciate it.
So, Bryan, besides those manuscripts, do you have anything else project wise that you're working on right now that our listeners should be looking out for?
Uh, the another interesting question, or at least I think it's an interesting question, is does technique matter, if you will? In other words, um, would a supine intervention compared to say like a sideline intervention, would there be any difference in kinematics? Would there be any difference in pain pressure threshold? Would there be any difference in clinical outcomes in side posture, for example, or side lying position versus supine position in terms of manipulation? And so for that particular question, again, just a little pilot data comparing those two type of interventions, as well as there was a control group, very limited sample size at this point. Again, there's maybe a handful, 4 or 5, but it does appear that at least in terms of the clinical outcomes, that there may be perhaps a difference between supine versus side lying position in terms of the clinical outcomes. But again, definitely, there's further testing involved to make any real solid conclusions. But I thought it was an interesting question.
And that is something that I have hoped to see pan out in research from an expectation standpoint. And I draw the listeners' attention more towards not just the patient's expectation or the patient's preference, but also the practitioner's preference. And I know Chad Cook did a study where he looked at equipoise and whatnot, but I really haven't seen that kick in a lot. And I'd love it to see if we can add even just a simple Likert scale to the practitioner as well as the patient on did they like the technique? Because I know clinically, at least when I was first getting comfortable with the thrust techniques, I definitely preferred side lying as opposed to supine. And I also know, having been the patient for a lot of peers who are learning those techniques, I definitely prefer when I have my treatment come through that side-lying position versus the supine. So I think getting kind of that insight from both of the practitioner and the patient's vantage point might also be an interesting question to pose as you move forward with that research. What are your thoughts?
Yeah, I agree. Again, just as a clinician, my own personal experience as a clinician, I have a preference. If you, my personal preference would be given a choice between supine and side lying. My personal preference would be a sideline position. Again, that just sort of probably reflects some of my training. Um, that's sort of that's how I feel comfortable. That's how I learned primarily how to do some sort of a lumbar manipulation procedure. So I just, that's my personal preference. But again, I think you hit the nail on the head, and that we have to consider, patient preference as well. Is there a patient preference for supine versus sideline position? And again, just anecdotally, my own experience tells me that patients oftentimes prefer the sideline position. I find that the supine position, sometimes patients don't like that contact over their ASIS,
Mm-hmm.
particularly like a high velocity thrust. Sometimes that doesn't feel comfortable for them. And as reported in the paper, we didn't, even in the treatment group, as far as cavitation popping, we didn't experience 100% cavitation or popping, even in the interventional group, and certainly in the sham group, the frequency of cavitation was very low. By contrast, I find that if I put someone in a side posture position, um, I more often feel like there's a cavitation, and the patient oftentimes reports a cavitation. And again, there's some evidence to suggest that cavitation is associated with like a gapping, if you will, of the facet joints, and perhaps again that's an important factor clinically in terms of the clinical outcomes.
And I always, and this is one that I've kind of gone back and forth on, and again, more of a personal question, but I always wonder about how much, if we are looking at a neurophysiological effect, how much of that cavitation is really important per se because of gapping at the joint or because of that patient's uh, perceived importance to that cavitation. Clinically, one of the things that I do, and one of the things that I've talked to students about, is the only time that I tend to target after a cavitation is if that patient has told me that they think that's important either through the subjective intake or by some other mechanism. And I've also talked to students and practiced personally of, instead of taking it from a here is a cavitation and that cavitation may or may not be related, I tend to treat that as a side effect when I describe manipulation to a patient that's naive to it. So I'll even go as far as saying that I would like to do an intervention, use patient friendly terms, and that it involves a very quick load or a very quick stretch. And from there, you may or may not hear popping sounds.
Mhm.
I just want you to know that they can occur. They're really side effects. I just don't want you to be freaked out by them if they do occur. Do you think that I might be pushing the needle a little bit too far in the cognitive perception phase as opposed to the kinematic and biokinesiology direction?
Yeah, so I think that's an interesting question, interesting thought. I do agree with you that patient expectations are important, and certainly, again, we see that in literature. We see, for example, that in Biolowski's model, that patient expectations are one of the mechanisms, or one of the moderators of response from manual therapy. So I think I agree with you again as a clinician that oftentimes if the patient expected that a cavitation occur and it didn't, then I felt as though in their mind perhaps that they weren't going to respond. Um, the way they wanted to. They sort of felt as though the job wasn't done until the popping sound occurred, basically. So I think you find that in patients, or at least some patients, that that's for them, that's a necessary part of the manual therapy intervention, and that again that's part of why it's so difficult to, I think, get to the mechanisms of manual therapy. It's complex, it's multifaceted. There are psychological aspects, there's psychosocial aspects. It is complex, it's multifaceted, and it's really hard to tease apart. But I would agree with you that patient expectation, good or bad, the bias that they may have, seems like, just clinically, that seemed to be something that would affect the outcomes. I don't know about your experience, but sometimes I could almost, predict a patient wasn't going to respond or didn't seem likely to respond just based on their attitude about, you know, being being in my office, basically. So I think that that's a powerful component to how people respond, or at least for some people, that's a powerful component to how they respond to manual therapy. So if they think the popping is a necessary component, then it's tough to convince them, tough to convince them otherwise at that point. So, but I think if they're naive to it, right? If they've never had that experience, they've had some sort of manipulation done or whatever it is, some type of manual intervention, then that maybe that isn't as important, that there's a popping sound, and to let them know ahead of time that, yeah, you may or may not experience a popping sensation. You may feel that, you may hear that kind of thing. Certainly, letting them know ahead of time, and perhaps letting them know that in terms of pain response, that it's probably more likely like a neurophysiological response that's modulating the pain, and maybe less emphasis on that biomechanical model.
And Bryan, I greatly appreciate your insight on my comments and my little side questions and whatnot. I'm going to tie right back to that expectation, which is a small anecdotal story. A patient who was coming to me with shoulder pain, he had received some imaging, and the imaging showed a rotator cuff tear. He was, I believe, in his late 40s, maybe 50s, and he came in, and the first thing he said out of his mouth is, I'm just here to go through the therapy that's required in order to get to the surgery. And I was looking at him. He had low disability, low pain, just kind of that perfect patient that should respond to conservative care. And over the course of about 4 sessions, he did. He had a decrease in symptoms. He was getting strong. And I kind of threw in at the end of that 4 session, like, how are you feeling? Do you think you still need the surgery? And not even a hesitation, just straight into it. Oh, I 100% need the surgery. That's why I saw the doctor, and they were able to move it up a week because of a cancellation.
Yeah.
And it was like, oh, you
Yeah.
got to be kidding me. But I guess we're forever cursed with the need to try to bring that research body, that knowledge that's out there, and just adapt it to that person who's right in front of us, who in and of themselves is a complex beast, as you were
Mhm.
alluding to
I,
before.
I agree with you. It's individualized treatment, right? It's not a it's not a panacea. It's not a cookbook. It's not everybody gets the same thing, and it is complex, and we need to, right, sit down with our patients and really figure out, like, what do they need at the end of the day, like what intervention do they need? Can we match the right intervention to the right patient, basically? And this idea that that it's not just all neurophysiological. It's not all biomechanical. It's not all psychosocial or other factors. It's a blend, and at the end of the day, the outcomes for manual therapy, right, are driven by multiple, or at least seems like driven by multiple factors, and we have to try to account for those in our patients, basically.
So, Bryan, thank you so much for providing us insight to your research, insight to your line of reasoning, and also really helping us out with adapting that information to that the N of one, that patient right in front of many of
Mhm.
our listeners. Now, that said, I'm sure that there are going to be listeners that have more questions or would like you to elaborate more and maybe just want to follow you as you continue your research career. What might be the best way for them to get a hold of you to ask those questions?
So I don't really have like a significant like social media presence, to be honest with you. I can be reached at my email, which is Bryan.Bond. So that's Bryan.Bond. So Bryan.Bond at stmary.edu. So again, that's Bryan.Bond at stmary.edu. I would welcome comments, feedback, whatever it may be. That's probably the best way to get a hold of me is just through email. Um, Again, I don't have Twitter or any other type of accounts. I'm not all that savvy when it comes to social media at this point. So just good old-fashioned email is probably the best way to contact me.
Well, thank you again, Dr. Bond, for all of your efforts, and we look forward to your research going forward. And I hope you have a wonderful day.
I appreciate your time, Kevin, and I appreciate the opportunity to speak to your audience at AOMT. And please feel free to contact me if you have any questions. I appreciate it. Thank you.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT.